complicated grief along with PTSD themselves. In its current state, we run that program 3 times a year, and that's for partners, parents, adult children, and siblings. In about 2020, as many people know, we saw a huge increase in the number of special operators that we were treating. My colleague, Dr. Brenner, is going to shortly be talking more about that specific programming, but we began running SOF-specific cohorts, which have frankly really taken off in popularity. A lot of people are really finding that it's particularly beneficial to go through this program amongst other special operators. So in its current state, we actually run that program once a month. We, over the years, have gotten a lot of requests for women's specific cohorts. So in 2023 and 2024, we ran 2 women's cohorts each year, but the popularity for that has actually increased a lot. So in 2025, we're actually looking to run about 4 to 5 women's cohorts. And then something really near and dear to our hearts. A couple of years ago, we were made aware that Native American and Indigenous veterans actually serve at a higher service rate than any other race, ethnicity, population within the armed forces, and yet tend to lack access to resources more than anybody else, essentially. So in 2023 and 2024, we've been fortunate to be able to partner with many different tribal communities across the nation, and we've run 2 cohorts specifically for Native American veterans. Our long-term plan, which I'll hit on a little bit later, is actually to run a mobilized version of our ICP, where we send a group of our staff to a tribal reservation in order to provide this intensive treatment with the idea of bringing care to these communities. And I won't read all of the inclusion and exclusion criteria, but just for reference, I do have that up there as well. So in terms of what our treatment for these veteran service members' families actually entails, everybody that comes through the program gets daily individual therapy. Typically, that's either trauma-focused care, PE, CPT, care that might be focused on anxiety, depression, other diagnostic issues in which we'd use the unified protocol, or if somebody is struggling with TBI or cognitive concerns, usually that would be cognitive rehab. Everybody that comes through also meets with a med manager and a case manager. We may make changes to their treatment while they're here in the program. A lot of what we're doing, though, is recognizing that we are a 2-week program, and our role is to make sure that they have really good care after they leave here. So we do a lot of connecting with home providers. We're very fortunate to also have an MOU with the VA. So we have an embedded VA liaison in-house 40 hours a week. He meets with just about all of the service members that come through the program. And he is wonderful at connecting people through the VA, kind of demystifying some of the concerns that many of our patients bring to us. He's also great at triaging any benefits questions that they might have as well. Everybody engages in group therapy, largely focused on resiliency, cognitive skills, DBT skills, in vivo exposure as well. And then we have a heavy emphasis on wellness. So most days our veterans are starting or ending their day with some kind of movement, whether that's fitness, yoga, art therapy. We have dietitians on staff that they meet with that also do cooking demos with them. One thing that I think we're very proud of is as we've gone on, we've gotten more and more requests for very specific concerns that patients are dealing with. And so we've ensured that we have staff who are very trained in some of these areas so that when a patient's here, in addition to their daily therapy, they can also meet with someone who might be an expert in substance use or in sleep or in parenting. I believe my colleague, Dr. Ward, is going to talk more later about the substance use piece specifically, which is the most commonly used adjunct service. Like all of our programs at home base, we are always very inclusive of family and support people. So within the ICP, we have 2 days that are devoted specifically for education and support for a loved one. We kind of view this as giving them a shared language, making sure that they know how to use a communication skill together when they're home, or they both know what might be helpful if their veteran is having a panic attack at home. We also work with the family members to ensure that they're connected with their own individual therapy and support after the program as well. And then we have recreational activities, some evenings that they're here, and then also that middle weekend, we typically have everyone go to a local horse farm for some equine therapy activities and some team building activities as well. So, a lot of data. If you're looking at your top left there, that is our program outcomes to date in the ICP. As you can see, we do have statistically significant reduction in symptoms across the board. And we follow people for up to 12 months after. So you can see that those benefits are really maintained as well. Many people enter our program at a moderate to severe level of PTSD and leave at mild or often sub-threshold diagnosable levels. Bottom left there is for our families of the fallen. We also, in terms of just some of our demographics, we have now treated patients from all 50 states, 13 other countries, all branches of service. About 18% of people who come through our program are women, and about 20% of people that we see now are special operators. What's great is the data does also show us that special operators in a special operator cohort versus in a general cohort do just as well. So a lot of it is about, their own choice in terms of what type of cohort they might feel most comfortable in. In traditional outpatient therapy, if you were to go once a week for trauma-focused therapy, it works. And what we see is only about a 50% completion rate. In our program since inception, we've seen a 95% completion rate. And we attribute that largely to certainly decreasing barriers to care, right? We bring people here, all they have to do is focus on themselves while they're here. And the cohort model as well. We hear that all the time, the fact that I'm going through this with 12 other people who have also experienced something similar to me. So in thinking of where we want to go next, we have some really exciting things coming up in the next year. We actually earlier this year, and some of you may have seen on the tour yesterday, did launch our virtual reality programming. That's been pretty heavily used within prolonged exposure and also within our in vivo groups. We are working with Dr. Sophia Mata to also launch acupuncture within our program in the fall. We have some pain programming that we're looking at adding in specifically around educational groups, as well as some extending of the physical exams to ensure that we're getting the best picture of someone's pain makeup. And then we're just beginning to explore wearables as well, specifically in the area of sleep. We're wondering about wearables that can give us even more information to better tailor treatment for individual people who are struggling with sleep. And like always, I think the thing that I love the most about the ICP is we are just constantly looking for populations that we have not yet reached or who really lack resources. So in November, I'm very excited, we are launching a fully Spanish-speaking cohort. That's largely a result of outreach that we've done with Wounded Warrior Project to areas like Puerto Rico. And so we're excited about the idea of having them all together, ensuring that they can all communicate the same language together. We have had times that only one person speaks Spanish, and that can be very isolating. So we're looking forward to that. As I shared later this year, we are planning to launch our first mobile program on a tribal territory. We've been working very closely with San Carlos Apache. Their tribal council has blessed off on this, so we are doing a lot of kind of last minute logistics, but we're really excited to be able to bring the care to that community. In March, we're looking at running a soft cohort specifically for women, which was actually a request that I've gotten a couple of times. And then a big passion for us is wanting to think through how we can bring children of the fallen programming. I mentioned that families of the fallen programming in line with Home Base's mission to really heal the whole family. We want to ensure that these children under 18, again, many who also witnessed or found their parent after the death, that they are getting the care that they need. So that brings me to the end. Happy to take questions later on, but for now, I'm going to turn it over to my colleague, Dr. Brenner.